Welcome to this channel, Surgeons in 3D Printing podcast. Today, I have a very special guest with me. He needs no introduction in the maxillofacial community internationally. I'm talking about Dr. Samer Srouji, head of Galilee College of Dental Sciences, professor and chair of Oral and Maxillofacial Surgery, Oral Medicine and Dentistry Institute of Galilee Medical Centre, Nahariya, Israel. He's a renowned AOCMF faculty and an inspiration for many maxillofacial surgeons in the world. So before we start this conversation, I recommend you to push the subscribe button, ring the bell for notifications, and to get updates of our new podcast releases. Without further ado, let's get started. Welcome, Dr. Samer.
Hi, nice to meet you. Thank you for this interview. And I want to share, I can't share. If you can just give me to share the...
Yeah, I can. Okay, you can share now.
Okay, so I will share.
Yeah, I can see your screen.
Okay, so I just want to show you first where I am from. So we are from the Galilee. It's the north of Israel. It's near Haifa and Nazareth, and I'm the head of the college, Galilee College of Dental Sciences, and the head of our Maxillofacial Surgery department, and we are one of the advanced, regarding this interview. So we are one of the advanced POC Center, Point of Care 3D Center in Israel, which is work almost end-to-end process in regarding maxillofacial surgery. Something that I will show you in next. If you ask me, what is these things, so if you want me to start, I can tell you that we are what we are doing now as part of the 3D center or 3D point of care center, as part of the first industrial revolution, as you know. So it's also the virtual reality, augmented reality, 3D printing, and the heart is the additive manufacturing.
Very true.
Yes, it's an aim start to be part of our revolution in maxillofacial surgery, as other things that happened in last decade. So the forecast search for it's more than $33 billion, which has become a huge number, as you know. And part of the things that become demands in this field is the AM professionals, which become it's about increasing all the time. In medical, in dental pieces, as you see here, it's become from 2017 to 2019, 2020, 1.65 billion.
Huge. That's a huge industry at the moment.
And we see here that the things is changing and become more and more in focused, as you see here in prototyping, anatomical models, patient matched devices, which become it's increased incredibly in 2 or 3 years, as you see here in this chart. Again, we are focused in point of care of 3D printing, what we call it now the POC. Okay, many of the hospital, universities, institutes want to have their POC in their institute, and it's something that become more and more increased all the time. This is more charting about the point of care setting, what's happening in different application. It's just published in 2020. Again, one of the challenges here, one of the challenges in this issue is the first one that it's marked here, as you see, this is the available workflow. It's a available workflow, workforce needed skills and knowledge. Okay,
Yes.
this is something that we should understand. Okay, and this is, sorry for that. This available workforce needed skill and knowledge is the first obstacle that you should overcome, and this is something that we did very good in the beginning. And this is something that you can see here when we started just 3 years before. We have many things to understand, what to do, what to think, which Microsoft, which things, what to do. And this is the first thing that we thought about. And in the beginning, you think about you are an OMS department, and if you want to do something, so most of what you are doing as seniors, attending, residents, okay, most of this is outsourcing. It's become high cost, and you can't treat your patient. This is something that become more and more difficult. So if you bring the know-how, you bring printers, and you bring all the fabrication that you can, and you bring your engineer, okay, and design, it's become much more applicable in your department. And the only thing that you can do at the institute or hospital is to print the titanium or to print a PIC. And this is the chart that you're showing. If you have more know-how, okay, so less outsourcing, less money, and become more a cost of technology, as you see here. Something that, and what you can do here, this is how you can bring our OMS, okay, or neurosurgeon or the orthopedic from one side to other side, okay, without engineering. And this is applicable to do it, and this is what, because we are demand to do something about this issue. Can we go straight, okay, from OMS to 3D tech application, okay, without engineering? Is it possible? Or we just think that it's not possible? So what's happening in the last years that many of the virtual surgical planning become more familiar with the surgeon and more of the cleared approved products. So many of them for KLS and other departments become more and more applicable. So something changed. So this is how we start. You can start with your devices. Bring your point of care 3D printing line as the printers, okay, polymers, cast, your software. It's very important to set up your hood. Everything should be done, okay? But the heart of what you are doing is actually your software, okay, your people, your doctors that working in the software. Because if they know what to do, so they, you can do this issue very good. And this is, how it's looking. This is one of our labs. This is the small one. We are now expanded for a much bigger lab. Okay, and this is, you can see here, this is the cast, this is the polymer. My resident that they can, do everything in this software from Freeform, Mimic, 3Matic.
Wow.
The two biggest, companies that we have today, Materialize and 3D System. And if we can, if we go just through what, this is one that is, so you can do the simple thing. The simple thing is to do the models. It's very nice that you can understand what you can do before you do your surgery, to understand your cases, and this is thing that we can do. Then you can take your model to the surgery, to the operative theater, and try to understand what you are doing online while you are making the surgery. This is the first thing that you can do it, so you can understand more what you are cutting and your edges and so on and so on. And this is what we call it. And then you can make the dry surgery, the vertical surgical planning, which is very important. If you have all the tools now, not just to understand the model, but also to make it virtually, which make it much more accuracy and so on and so on and so on, and to understand as what with that. And can we make plate or other mesh pre-bending? If we can know what we are doing now in our surgery, can we pre-bend and save time and money in the operating theater, so we can do it much faster? And this is something that we can do it. We can do it also in different reconstruction jaws and plates and other that we can just do before. So the only thing that we can do it in our situ is the printing. Okay, so we just have everything, and so we can send this STL file, okay, to next door. So in the next door they can print it or can send it back 2 days, 3 days, depend which company we are working with, and then we can go through the operated theater. And this is, the workflow was different, as I will show you with trauma. And the core of this thing is my staff, is the resident, is my doctor. So they can do the segmentation, they can do reposition and memorying, they can do printing of the middle, plate pre-bending, they can do design, guide, everything, and print everything. And in the end, okay, we send it the PSI for printing and do everything by ourselves. And this is what means segmentation. As you know, Richie, it's from 2 pixels to 3 pixels. And then we can make the repositioning, memorying, we can use different, we can go through this. Okay, then we can go to the printing, as you see here. And this is, as you see here, this is printing. You can do print and use it as a model for anatomic prepared, as we want to do in our surgeries, and we can make that pre-bending, as you see here. Okay, and then the important thing is the end. Okay, is to design our plate. So if you can design your plate, okay, you make 95% of your process. Because
exactly.
Just, you need a company, that can do the printing in QC and very high QC, and that what we can do. And this is how we can do it. It is pre-bending, in the surgery, so you can do it, and it works very nice with very nice results. And we can do, as you see here, in custom made. As you see, we can make custom made, and this, as you see, also very nice results. We can really, by memorying and by designing, do it very nice. And this is a case report, as you see here, a case that we design it very nice. Okay, and we have maybe I'll try to show you later a video how we do it. And this is how it's work at the end. You do it, and then in the end, this is the CT after post-op, and this is the case before and after. So everything done in our book. Okay, just the only thing that we did is the so this is late reconstruction. This is very difficult case. After this, I want to show you, because everything's done here. The only thing is just to have all the tools. So this is a very difficult case of reconstruction, and should be reconstruction from the beginning. And so our resident can make the soft tissue, then we can start memorying and try all the surgery now we are doing it virtually. So we first want to change the position of the zygoma. So we have a guide and repositioning of the zygoma. It's not just cutting, it's also repositioning. It's something very clever to do.
Wow.
Then we use how to make all this stuff together, to make the planning of frontonasal. And then we start the surgery here, go to operator theater, we have all the stuff, and we go, as you see here, so we can go through, and as you see here, you go through all these surgery, you take out the plate and start make the things together. This is the guide, and after you have the guide, you can go and make the repositioning of the zygoma. After you cut the zygoma and you reposition it in the plate that you design in your virtual designing, and then you go and you move the zygoma as you see here. Then you put then you put the floor of the orbit as you see here. This is the floor of the orbit. We put it, okay, and now we can have all the position again. Then we put the plate to not that reduction, but to fixate all the construct that you did. The same here as you see. This is after, you can see that we reconstruct everything after, and this is just 10 days after the reconstruction. This is how it's look, 10 days after reconstruction. This is 2 months. As you see here, we change everything for this patient by virtual planing and by right, because otherwise without this tool in your department you can't have these nice results. As you see here, it's almost perfect. He have soft tissue problems here and there, but most of the hard tissue is in the right place, as you see here. And then you can check yourself, before and after. You check what you have and what you're designed, and if you did what you think you should do. This is the nice thing that you should do also. This is the same, when you go to orthodontic surgery, and I will go, because I think don't have enough time, but as you see here, we can go same with segmentation and repositioning by problem software, and then we go and you hear me?
Yeah, I can see you, I can hear you.
Okay, something happened. Okay, now, and then we can, go and make the surgery. The same, same concept, but different surgery. As you see here, we can also design everything, design the plate, design everything, which make the surgery much easier and much nicer. As you see here, another with wafer, the same, No, it's different concept. It's different tool that make your surgery more applicable and more suitable, with more accuracy, and something that you can accept before and after you start your surgery. So you have many things that you can understand what happened to you. If you will have face any complication, you can, with virtual surgery, you can understand. And many of these is something that we did, and it's not related to this concept, but we know that it's very accurate in this. And what you see here is oncology is the same. Okay, when we make oncology cases, also the same concept with the same. We have here, as you see here, we can do cutting, okay, and go through, and as you see here, and we make the virtual surgical planning, the cutting, the reconstruction, okay, resection of and we can go through, we can take from the ileum, reconstruct it. It's very, very useful tool to have, much more applicable, much more, something that you can be more, not just safe, but you can be more confident with your surgery, and make you much. I'm not saying much better surgeon, but something that you can understand more what you are doing, okay, with much more better accuracy, with very nice result. As you see here, you can also check what you are doing, okay, in very, very difficult cases with MRI, and you can make superimposition between the CT and the MRI. Understand? Okay, so superimposition is very nice to do, and as you see here, then you can reconstruct it with the zygomatic implant, And this is very nice case to see. Okay, so we can take and we can, with plate, with designs, and with special guides. You can do all that surgery. You can do it very, very, very not easy. I can't call it easy, but much more with much more confidence. Okay, and with much more accuracy, precisely. So something that no doubt, it's something that, and this is the case before and after. This is a young woman, okay, with this case that just after the surgery she has the same we can do with operator after resection, with all cases. Okay, we have different cases that we can show you here, but other implication that we can use, okay, very, if you have lesions here, so you can do guided injection. See, that's very nice to do it, and very simple to do.
And it is a very simple procedure. I mean,
yeah, it's very simple procedure and very simple, guide. So you can do it, in 1 hour, and so it's not dependent doctors, physicians.
And anybody could do exactly.
Anybody can do it, and you see the same here. Okay, and the same, the TMG surgery, the same we can do in TMG surgery. It's for, just to understand that in cases that we can see where the teeth dropped, in case that was a complication in one of the dentists.
Wow.
Malunion.
These are so many variety of cases. Amazing.
Yes. So there's many cases that we are doing, dependent of this tool. Okay, so I think that you understand that this is something much dramatic, because something that we can use it for, very difficult fractures. So we can make correction of the fracture by virtualization. We can pre-bend the plate and make the surgery much easier. Something also for research is very nice. It's ballistic, okay, but something that can I show you. So let me just try. I just want to not stop share, but finish the. And I want to show you 1 minute. Stop sharing. Again, 1 minute. I would just want to show you a thing. I hope I have it here. I put it. It's 1 minute. It's a video about it's let me see if this video is here. And I can show you here if you want the augmented reality that we did.
Yeah, that's what I was seeing, that you started using augmented reality after 3D printing. So did you find this change that you're printing less now? Did you realize, I mean, did you kind of have that experience that augmented reality led you to print less?
Augmented reality, it's the first steps, that it's just in the first steps reach, it's not something that well based. Okay, so this was our first case, and we did another one case. Okay, it's not easy to do, because the registration should be very, very accurate. Okay, and we make all the things together that make it really accurate. And I think we did very nice one, because we milked the head, and I think HoloLens 2 now it's much accuracy. And what we did in augmented reality, it's very tricky, because what we did, we just designed something. Okay, we designed the place of the plate, and then we just take our design, okay, and put it on the patient. So when we put the plate, we can see where the plate is and where our design is, so we can see the superimposition. So if it's superimposition, so we are in the right place. It's something that we can use it as navigation and other side that we're using now in this is. Let me try now to show you. This is the case of
I see a lot of ballistic injuries and high velocity injuries that you showed for this this website. I mean, just showed. So I'm seeing that there is a lot of high velocity trauma coming in there.
Yeah. Yes, not just this. Let me show you this now. Okay, this is something that is can you see it?
Yeah, I can.
Okay, so this is the augmented reality that we did. Okay, so I can show. So as I told you, what we can do, okay, we can make. So we can make the design, okay,
right,
of the plate. You know, after diagnosis, we can make it in our place, okay. So after we design the plate, okay, we can take this design, okay, and try to supplement with our patient. So we know we have the plate, okay. So we can put or try to insert the plate in the place that we designed before.
Okay.
So how we should know that the plate in the same place that we designed before? Okay, as you see here in this model. So we take our design and put it there, and so we can see exactly if there's a superimposition. And if there is a superimposition, so we are glad. Okay, we're working very, very good. Okay, so we can finish the surgery. Okay, and this is very nice to do, and we can do it in line. It's not easy. Okay, and I think it's, you see, the final result was perfect for this case.
Okay.
And this is something that we just try to do again.
Amazing.
So this is what I have, Srouji. I think.
And I think 3D printing forms the basis of this as well. I mean, you have to know 3D printing still. I mean, I think that's the heart. 3D printing is the heart of all of these technologies. I mean, somewhere.
Yes.
So now, can I ask you a few questions, very short?
Okay.
So you've gone a very long journey now. You've been doing all of this 3D printing and virtual reality, of course. But when you started, what intrigued you towards these technologies? Like, where was your trigger point of getting interested into technologies? What attracted you to actually learn these technologies?
What attracted me, I think, is that, it's something that when you start to be aware what's going on around of this technology in other, not just in healthcare, other things in other fields, and you understand that this technology can make your patient, your surgery, and make better for your patient. Okay, and this is the most important thing that attracts me, that we can do better for our patient, And this is what I told you in the beginning. One of the obstacles that we knew that we can do better for our patient, but we can't do it because it's very high cost. And this is what we try to do, okay, to overcome these obstacles.
Right. And so, can I ask you another thing? What do you think is the learning curve for virtual surgical planning?
It's very dependent. If you ask me about doctors, talented doctors can do it in 1-2 years. If you have one doctor that he can be detected to this, okay, field, and I have two like this in my department, and they're doing very, very, very nice job.
Right.
It's not easy learning curve. But it can be done perfectly.
Right.
And so I think, I'm the thing. Not sure that engineers should do these things. Also, doctors, okay, can design in at least in our field, because it's differently. Because when it's surgeon design, okay, when he go to the operator theater, he do it much better. And you understand every half millimeter what's going there. If there's something, really, it's incredible. When you design and go to the surgery, it's really different thing and different. Really, it's really different case. It's different, issue. it's different thinking, and you feel that you do it much with much confidence than when you go blind, just make this section, trying to do like this and like that, let me check, let me cut. No, it's different opera. It's
right.
Different opera.
Right. So how do you suggest should a surgeon start training? For example, I have to train one of my, say a resident has to be trained particularly for VSP. Do you suggest a surgeon to be separately trained for VSP? And how?
Yes.
And how?
No, I think it's be more involved in surgery, more involved, in courses. They should design and go with the senior to the operative theater to understand where they it's the learning curve, but they should understand first to be familiar with the softwares, and the software is not so complicated. It looks complicated, but it's not really complicated. So if someone be focused there, and he can also operate and design, this is the best thing that you can do for your surgeon.
Right.
It's different generation, and it's different generation, and it's look really promising.
Right. So do you have an engineer in your department? Do you also have engineers? No. Wow. So that's amazing that you're managing the whole workflow without engineers.
Yes, this is this is make our work much cheaper. This is the only thing that make our if I need the engineer, so I just hire one for 1-2 hours. If I need something special, but engineer in my department know most of what you saw, all what you saw, and what I show you. It's my doctor.
Wow. So that was amazing. I mean, I was blown away. And I think, I will be putting it up like a podcast, but I think it even serves better if it is on the YouTube as as showcase it like a presentation, because the whole presentation was amazing and we had a lot to learn here. So thank you so much, Doctor.
Thank you. Thank you.
I understand it was a busy schedule, but you managed to take time, and thank you very much.
Thank you. Take care.